this event along with NHRC. And as ma'am has informed that today's session is on osteoarthritis approach to the management. And we know that osteoarthritis is a degenerative joint disease condition and more prevalent in the older peoples, and its onset started early 40s and the 50s. But many times younger people are also affected of due to this particular disease, especially the athletes or people who sustain different type of joint injuries because of the trauma or other cases. And we also know that this is a disease which significantly contribute in year lived with disability, which we called as YLDs, and it is ranked seventh cause of the YLDs among older generations. According to the Lancet, globally since 1990, there is increase in almost more than 130% of the cases in osteoarthritis. And if we talk about Indian scenario, then we know that we are moving toward aging. So this topic is very, very pertinent to talk about. So to present the session on osteoarthritis, we have a very own Dr. Sangeeta Sharma, and ma'am is basically the professor in IBHAS and also president of the DSPRUD. And ma'am is going to talk about osteoarthritis issues and challenges. But along with that, we have Dr. Anil Jain. He is the Director Professor, Department of Orthopedics, UCMC Delhi. And very, very warm regards to ma'am as well as to the sir for coming up in the Saturday to deliver this particular talk. And I hope all the specialist doctors as well as the professionals from the different background who has joined us, as well as I think few of the staff nurses, specifically the CHOs, that is community health officers, all will be benefited from this session. And once again, thank you, ma'am. Thank you, sir, for delivering this session. Over to you, ma'am.
Thank you, Deepika, for introducing this session and arranging the session for us. Uh, I'll like to start. Dr. Anil Jain will follow my this thing my after my session. Meanwhile, I think participants have already attempted the pre-test. Please try and finish it. I've got only 56 replies here, whereas we have around 90, more than 90 people in the room. So if you are in the process of clicking it, kindly do it quickly. Meanwhile, I'll start my this. Are you able to see my screen? Okay, good afternoon, everyone. I hope you are able to see my screen.
Yes, ma'am. It's visible.
Okay, good. Why is this topic important? Deepika has already given you the preamble. Uh, this is one of the chronic diseases which is affecting, earlier thought of that it is affecting the older people, but other younger people are also affected. And there are many other challenges that come with the osteoarthritis that if they go unrecognized, they affect the quality of life of the patient as well. So now let's see, okay, there are several challenges primarily related to the misdiagnosis and mismanagement of osteoarthritis. You would say, what is wrong with it? Osteoarthritis is so simple to diagnose, and management is also quite straightforward. But there are various issues which revolve around, or there are various factors which increase the complexity of the symptomatic presentation of these. You may mix it up with other joint problems or other issues, and there are other overlapping issues that may affect the diagnosis. And sometimes, because if we don't have proper training in diagnosis and management, patient may continue to suffer and their quality of life may differ. Symptom overlap is a very, very significant challenge that we face when we handle osteoarthritis. This can be misdiagnosed or overlap with rheumatoid arthritis. Is a very prominent confounder here. Gout and fibromyalgias, these are other overlapping symptoms that may confuse us whether we are dealing with osteoarthritis or not. Then patient may present with joint pain, stiffness, reduced range of motions, which are common to many of these rheumatic diseases. So the line of treatment for both rheumatic arthritis, osteoarthritis, gout are entirely different. So diagnosis has to be correct, and if it is not, the diagnosis is not made in time, it can lead to delayed treatment of the patient. Then one of the very good diagnostic modality for osteoarthritis is the X-ray, uh, uh, which most of the time is able to delineate the changes in the joint, and you can make a diagnosis. MRI or ultrasound are needed sometime to look at the soft tissues around, what's happening. But the access to these modalities may be limited, particularly in a primary care setting. But by and large, X-rays are able to help you with the diagnosis. So if you don't have access to any one of these, then the physicians have to rely on the clinical examination, which can be subjective, may not always provide a comprehensive assessment of joint damage or disease severity. And also, particularly many a times, because we are short of time, there is heavy patient load, we may not give that much of time for assessment. And we've seen, many of the acute conditions take priority when you are sitting in your clinics there, at wherever level of healthcare you are working. So this being a chronic condition may, we may not evaluate properly clinically. So because this is given less priority, because we think that this is inevitable, this is consequence of aging, and this is bound to happen, people need to suffer from this. But we fail to recognize that there are physical, emotional, and socio-economic burden of osteoarthritis on their patients. So which can, if there is a suboptimal treatment or strategies are not properly adopted, it can affect all these aspects of the patient's life. For example, I am in a age group, I may my outlook could be, okay, I'm aging, I may this is the time to begin with these all these osteoarthritic problems. But is there any way that I can extend my functional or mobility for a longer time that will help me in achieving good quality of life for me? Now, management is multifaceted. It needs lifestyle modifications, exercise, weight management, and pharmacotherapy. So we need to know, when to use what, and when there is an end to each of these strategies. How long will you rely on one particular strategy for the management? So that's one aspect of the management of osteoarthritis. Second is that you many times we neglect the comorbidities. for example, obesity, diabetes, cardiovascular disease, they can exacerbate osteoarthritic symptoms and hinder with the treatment effectiveness. The ultimately the result is that these patients are on polypharmacy. As you know, polypharmacy means taking more than 3 or 4 drugs for their management. And since these patients may have comorbidities, they may be on certain drugs which may interact with the NSAIDs, which is by and large the first line management of pharmacological management of osteoarthritis. So there could be exacerbation of patient symptoms, which may compromise patient safety. And one of the particular challenge here in osteoarthritis is that many a times non-pharmacological interventions are ignored. Dr. Anil Jain is going to talk about this, but if adequate trial or these non-pharmacological approaches, interventions are not optimized, then we may be taking decisions prematurely for intra-articular injections or surgical options. So, or there is another spectrum of patients who, who are reliant only on medications. And we know NSAIDs being the mainstream analgesics for this age group, and if they take it for years together, for a long time, then there are side effects of these NSAIDs. Also, these side effects, the one of the prominent side effect is gastric acidity, and for which proton pump inhibitors are co-prescribed. Now, there's nothing wrong with it, but since the treatment is going to continue for very long period, there are chances that these patients are also remain on these proton pump inhibitors like omeprazole or pantoprazole or rabeprazole. In the short term, there is no problem with this, but on long-term treatment with these PPIs, there are a lot of serious side effects that are associated with it. Fractures, deficiencies, increased infections. These are some of the side effects of prolonged PPI therapy. Many of us believe that PPIs are safe drugs, but actually they are not. There are many studies that have reported kidney problems because of this magnesium deficiency, calcium deficiency. These patients may have more falls, and elderly, as you know, if they have falls, then it can limit, it can be quite debilitating. I've seen many patients, they are not able to become mobile again once they fall, because this vicious cycle starts, that they are bedridden, they are not doing any exercise, the body, you know weight will increase, or the muscle strength, or these things are affected. They are not able to come back to the normal life. Secondly is the what is the dose in which these paracetamol or non-steroidal anti-inflammatory drugs should be chosen. Another question arises whether these drugs should be taken continuously or on demand. Can it be given? Then what is the dose of this safe dose? Because a lot of new several non-steroidal anti-inflammatory drugs are available in market. How do you make a choice between them? I think we will see after the session, Dr. Anil Jain will be talking about it. But by and large, paracetamol is the first line, and 4 grams, 4,000 milligram in a day is the maximum dose that can be given. If paracetamol is not working, then you can choose another NSAID. Many people misbelieve that if paracetamol is not working, the none of the NSAIDs will work. Or there is another way also. People think that paracetamol uh, is a antipyretic agent. How and what effect will it have on uh, uh, pain? But paracetamol is the most studied, old, well-known drug, uh, and it's quite safe, and it has good analgesic activity as well, besides being an antipyretic agent. So, what all NSAIDs are chosen, that will decide the adverse effect, and it may limit the lifelong efficacy of these. Then another controversial area is the nutraceuticals. There are people talk about dietary supplements, herbal remedies, and functional foods. They have gained attention because of their potential role in managing osteoarthritic symptoms and improving joint health. There are substances like glucosamine, chondroitin, omega 3 fatty acids. These have been studied, but there is no clear cut evidence whether they are anti-inflammatory or cartilage protective. And other thing that you need to look at it, uh, you have to balance it, because the evidence is mixed here. Some studies suggest benefit in reducing pain and improving, but others are not supporting it. So, and these are quite costly medicines. So one has to really look into this, before you prescribe these nutraceuticals. Non-drug therapy has non-pharmacological treatment is very important, is the primary thing. Physical therapy, exercise program, occupational therapy, they can help in achieving improving the joint mobility, strengthen the muscles, and enhance overall function. Many people misunderstand or use massage with the physiotherapy. They think massage is physiotherapy. You may be wondering, how can anyone think like that? But I've seen many patients thinking that वो massage कर रहे हैं, तो they think that it is the physical physiotherapy. And also occupational therapy is underused. These here in this, they try and teach you to make more functional. So there are many other modalities, techniques of non-pharmacological treatment, like manual therapy, acupressure, TENS. They can also provide symptomatic relief and improve quality of life. But basically, if you look at the core, is the weight management and lifestyle management, and along with dietary changes, the overall patient management can be improved. Then inappropriate use of injections, intra-articular corticosteroids, or hyaluronic acid. This may be overused, misused in management of osteoarthritis. So particularly because these things require proper patient selection and consideration of potential risk. And as you know, that this is the invasive form of management. It can lead to complications, infections, joint damage, and temporary symptom relief without long-term benefit. So the patient may need more injections over a period of time. And underestimation of surgical option is another challenge that we have. Sometimes patients and their doctors also, they rely more on the conservative management, and they may underscore or underestimate the surgical options, just such as joint replacement surgery. Now this surgery has improved. Robotic surgeries are also, bloodless surgeries are done. Patient can be functional immediately after surgery. Not much of bed rest or physiotherapy of course is required, but they are functional very soon after the surgery. But if you delay or avoid these surgical interventions when indicated, can result in prolonged pain and functional impairment for the patient, so again diminishing the patient's quality. Then one more thing is that these patients should be referred to specialist on time. If there is a delay in sending for the specialist care, or when you are in doubt, the patient should be sent to a rheumatologist. Even if you send it, I understand there are not many rheumatologists just in the country, and many states or districts may not have one, but at least referral to a orthopedician would be helpful here, because they can evaluate and make a diagnosis. What is it? Is it OA or rheumatoid arthritis or gout or any other illness? So again, delayed will prolong the suffering of the patient. So ultimately, the lesson from if you look at the management approach of osteoarthritis, we need to tailor treatment according to the individual needs, preferences, and the physician, what is available, at which level of healthcare are you working, so that you minimize the risk of polypharmacy and yet give proper support or management to the patient, so that they remain functional. There are many patient related factors, because of low health literacy, misconceptions, they may not come forward, but surgery, I have seen, I've seen many patients limping, hardly able to walk few steps, but yet they will not go for the joint replacement surgery, because they have some, word of mouth from another patient, ये अच्छा होता है या नहीं होता है. They may not accept this, but anyway, since we are working for integrated management, where you are working with managing lifestyle, exercise program for the patient, drug therapy, and at a time when surgery may be more. A solution is that we increase the awareness, knowledge, and collaboration of healthcare providers here to overcome these obstacles and improve the diagnosis and management of osteoarthritis in primary care setting. I think many of you may be already knowing standard treatment guidelines. We have a full chapter on bone related problems, bone and joint related problems, and osteoarthritis being one of very important this thing. All these non-drug, which works, which does not work, how much of that should be done, which drug, what is safe, what is the next level, and then when to give intra-articular, all these things are very well prescribed here. We are in the process of printing the 7th edition. I think by next end of this month or April, you will have it there. So if you like, besides this osteoarthritis, there are many other diseases that are being discussed here in this book. I think Dr. Anil Jain, has he joined? Siddhi, can you find out? I don't think so. He has joined.
Ma'am, I just spoke to sir. Sir is joining in 2 minutes.
Okay, fine, good. So meanwhile, I think you all have finished with the pre-test while we are waiting for him to join. We've got 78 responses, no more responses on this. Okay, if there are any questions, you can write here. If I'm able to answer it, I'll answer, or we can, after the session by Dr. Anil Jain, we can have that question and answer session. There is a link in the chat box. You can start attempting that. Those for the certificate. Siddhi, you can and make the announcements regarding the YouTube here, and you can tell them the procedure for issue of the certificates, because many people keep asking for this. At the, I think Siddhi would be about to join. Uh, the procedure here is that all those who have registered for the webinar and they sit through the entire program and take the pre and post both these tests, they are issued the certificates. Now, sometimes the email ID, if it is different from which you take the pre-test or from where you register, can get this problem that you may not get this. So because they will at back end will match these three things: registration, your attendance in the webinar, and pre-post Google form email IDs from where you attempt this. So please make sure that you attend and take both pre and post. Those of you who take only one of these, either pre or post, will not be eligible for the certificate.
Ma'am, sir is joining in sometime because there's some technical issues which he is encountering. IT person is helping him.
Okay.
Yes. Ma'am, for the certificates, we are issuing for the people who have attempted both pre and post test. And if they have any queries regarding the certificates, can write us on htg.webinar@nhsrcindia.org. I'll be posting the email ID in the chat box.
Yeah, put that email ID in the chat box so that they can write to you directly.
Yes, sir. Yes, ma'am. Yes, ma'am.
So that is why we keep announcing that you take both pre and post test both, because if you don't take one of it, you will not be eligible for the. Yes, how many times the tablet paracetamol is given 6 hourly? 500 to 1000 milligram can be given as one dose. But if the pain is severe, patient may take it earlier, but not earlier than 4 hours. It should be spaced at least 6 hours between the two doses. Maximum dose that you should not exceed is 4 grams. If the patient is having other comorbidities, particularly if there is a kidney problem, then it can lead to overuse of these paracetamol can lead to kidney problems. If there is a chronic kidney disease, then you have to halve the dose. Then maximum dose per day is 2 grams only. Then one more thing with these paracetamol, the dose is counted. This includes from all sources. Many a times, some patients are taking fixed dose combinations, and there is a paracetamol in those fixed combination as well. So it is when we say 4 grams, it is the total dose of paracetamol that should be given from all sources. Over the counter or fixed dose. Now, there are various preparations of these paracetamol are available in the market. Particularly be careful about Dolo is one brand, that, became very popular during COVID. It has 650 milligrams of paracetamol. Traditionally, up till now, paracetamol was in the dose of 250 milligram or 500 milligram tablets were there. But this is 650 milligrams. So just, the dosage strength of crocin and Dolo may not be same. Many patients also get confused. They think Dolo is something else, but it is paracetamol only. So be careful when uh, when you prescribe this. Uh, Step up approach, adequate trial. I think this question, I also had this, but genuinely we need to look at whether there has been lifestyle modification approach or not. Whether the patient actually tried with these exercises, whether they are complying with it. The patient may also sometimes say, man, I tried, but it is not helping, because these initially these exercises or programs may be painful. So you have to make a clinical judgment here, most probably, that whether the adequate trial has been tried. And many times, if one of the strategies not working, if you change it or intensify it, then it works. Okay, now Dr. Anil Jain has joined. Welcome, sir, Dr. Anil Jain. We
Thanks,
have
Dr. Sangeeta. Yeah.
no, it's my great pleasure to have you here with us for today's session. Already there are many questions for you in the chat box, but we will listen to your presentation first. Siddhi, can I have his introduction slide so that I can introduce him? Sir, already before you joined, I've just given them overview of the problems encountered in the management of osteoarthritis, the challenge such as overlapping of symptoms, uh, these diagnostic difficulties, then non-drug trial, adequate trial not being given for that, or intra-articular injections, overuse or misuse, similarly, or deferred surgical options. So just gave them the overview. Okay, now we welcome Dr. Anil Jain. He is Director, Professor, Department of Orthopedics at University College of Medical Sciences in New Delhi. He was principal of this college some time back. And now he has gone back to his department as director professor. He is editor in chief for the journal published by National Academy of Medical Sciences, Annals of National Academy of Medical Sciences, and he has been also ex-dean at Faculty of Medical Sciences, University of Delhi, and past president of Indian Orthopedic Association. He's been trained for spine surgery at Harlowood Hospital, Queen's Medical Center, Nottingham, UK, and Royal Hospital for Sick Children in Edinburgh. He is listed amongst the top 2% of scientists from India. That's great, sir. That's a very great being in the top 2% of the independent study by Stanford University scientists on Google Scholar for past 4 years. And he has been very active academically, has 200 publications with more than 6,000 citations. I think that's a commendable achievement, and we couldn't have had none other suitable person for this session today. Over to you, Dr. Anil Jain.
Thanks, Dr. Sangeeta, for generous introduction. Well, shall I share my slides or?
Yes, sir. Yes, sir. You can run it from your end. Otherwise, we can also do it.
Yeah, okay. I'll just share open system preference. How do I do it?
Sir, go to this share wala button दबाइए.
And allow WebEx to share open system preferences.
Siddhi? Siddhi?
Sir, on your screen,
Yeah.
like when you open the presentation, you can.
It's already open on the background. It's already open in the background.
Okay. Okay, sir, you just have to share it from the top of the. Sir, can I share it from my end?
Oh, yes, you can do it, please. Thank you. Yeah, so nice of you. Will I'll be able to change the slide myself or?
No, sir,
नहीं
just
सर,
tell
आपको
next
बोलना
slide
पड़ेगा.
please.
No, I think then it will be too much because it has some animation with the in between change. Let me do it from my end only.
Okay, sir. Okay, sir.
Yeah, okay, share and then open system preferences.
उसमें एंटायर स्क्रीन पूछेगा या आपसे पूछेगा कि आप ये वाला प्रेजेंटेशन ओपन करना चाहते हैं?
Okay, just a minute. Let me open the मुझे लगता है ये एप्पल का इशू रहता है.
हाँ सर, ये शायद उसमें थोड़ा सा डिफरेंट है एप्पल में.
हेलो या
सिद्धि,
हाँ मैं किसको अच्छा इधर से म्यूट कर देता हूँ. ओके
Yes, ma'am.
नहीं तो कंप्यूटर शेयर करा दो फटाफट. पर आई डोंट नो वो हो पाएगा कि नहीं.
Ma'am, I guess he's talking to the IT person there.
ठीक है, ठीक है.
I'll share it from my end.
हाँ नहीं तो कर लेना.
या आप एनिमेशन हटा दीजिए उसमें से सारे और क्या. So yeah, am I audible?
Yes sir.
Okay, so the what I have to speak is about approach to the management of osteoarthritis. I think by definition, this is not a true arthritis. It is an osteoarthrosis, which is also known as osteoarthritis because it's primarily a disorder of synovial joint. Next, please. Uh, uh, the primarily cartilage damage takes place, and as a result of cartilage damage, secondary changes in the adjacent bone and soft tissue takes place, and that produces some inflammation, and that is why it is being labeled as an osteoarthritis. Otherwise, it is in true sense it is an arthrosis. Now, it is a common degenerative disease, and because it is characterized by local, now you could see this is the bone, and all bone ends are covered with hyaline cartilage at the end of the bone to make a joint. And once degeneration of this cartilage takes place, as a result, and this local degeneration of joint cartilage takes place, and this cartilage, next please, I think next, yeah. So as a result to this, new bone formation occurs at the base of subchondral bone. So beside this, beneath this cartilage, the bone which is just next to it is a subchondral bone. So there is a new bone formation takes place here. And once this cartilage, which is generally 5 millimeter on either side, and this cartilage loses thickness, so there is some instability comes in at the joint, and as a result of this instability, nature tries to stabilize the joint by making osteophytes at the end of the attachment of the ligaments. So new bone formation is taking place here and at the joint margin. So that is called as osteophytes. Now, how and why it occurs? It occurs due to mechanical and biological event. I think we need to understand what is the mechanical is, that if whenever there is a movement in the joint are concentric, and as well as parallelism of the two articular surfaces is maintained all the time, so that the movement between the two surfaces is very smooth. Now, if there is any mechanical derangement, be it maybe because of deformation of the head, or be it maybe because of any reason, whether it is because of fracture or any reason, if there is a mechanical derangement of this parallelism, so that is one event. And the other event is that this cartilage, by a biological reason, loses its thickness, goes into a rapid degeneration. So these two events leads to destabilization of normal coupling of degradation and synthesis of article cartilage and subchondral bone. Whenever the cartilage is insulted, it goes into regeneration. Similarly, subchondral bone, if it undergoes some microfractures, it regenerates by itself. So this balance is destabilized, and that is why the whole process of degeneration occurs a bit faster. Next. Now, who gets it more often? And that is what is a risk factor. Older age. In older adults, this degeneration takes place more often, and rarely it is under 40. Well, it is generally been seen more in the women, maybe some biomechanical reason or something, but somehow it's more known in the women. Bone deformities, there are certain developmental conditions which leads to deformed bone, or any conditions after the birth where some deformity of the joints has taken place, and which leads to prone for cartilage defects, or previous joint injuries, whether it is a known fracture or minor unrecognized fracture, which may be sport related or following accident. Any reason, if previous joint injury produces a deformation of the joint surface, then it is prone for secondary osteoarthrosis. Obesity, yes, you per square millimeter weight transmission becomes multiple times when the person is obese. So you can imagine, if a person of 50 kg when walks on normal movement, then the knee transmits 3 times of the body weight transmission takes place at the knee joint. However, when the person runs, then it is almost the 5 times. So similarly, if a person is of 80 kg or 90 kg, so one can imagine obesity leads to carrying more body weight, places more stress on your weight bearing joint, such as the knee. Now, other disease of bone and joint can also destroy the bone, and these disease may be, and that is why a joint which is being affected by some disease sometime will leads to degeneration faster. And the example could be a gout, where the crystals damages the joint, or rheumatoid arthritis, or Perthes Paget's disease, even sequelae of septic arthritis, where joint deformation has taken place, or sequelae of tubercular arthritis. So if any disease has taken place to the joint, then I'm sure this joint is going to undergo degeneration faster, and secondary osteoarthrosis will develop. Now, how do we classify them? There are two kind of osteoarthrosis: primary, which generally occur as a aging, and particularly some prone in some particular sexes, like more prone in the female, or secondary, which is due to secondary cause. Next. So primary osteoarthrosis, generally cause is unknown. Now here, primary osteoarthrosis means there is no underlying disease or damage to the joint has taken place. It is just by a natural degeneration of cartilage, and the cause is unknown. Why it occurs, nobody knows. And the speed of cartilage degeneration is variable. In some patients, some persons, it is faster, occurs at the early age, and some persons it may not occur even at the 80 and 90 year of age. But certainly some degeneration of the cartilage takes place with old age. More degeneration takes place in obese, and it is said that hereditary factors play some role, and that is why there is a variable degeneration of cartilage, primary degeneration of the cartilage. And all joints are prone, Metacarpophalangeal joint is one of the most common joint, then the knee, then the hip, and first metacarpophalangeal joint is again more prone for primary osteoarthrosis. Next. Now, secondary osteoarthrosis, as I said, it is because of a pre-existing inflammatory disease like rheumatoid gout, or injury following trauma or following any operation, infection following a pyogenic infection, or sequelae of tuberculosis, or some ligamentous deterioration or instability present in the knee joint, as happened in the persons engaged in active sports, or as the result of obesity, or some crystal deposition in alkaptonuria, or certain congenital disorder of the joints like physical disorder, as well as some congenital disorder of the joint like congenital insensitivity to pain. And this is a condition where, although very rare condition, where there is an insensitivity to pain, and that's why these joints are stressed beyond the normal limit, and these joints are damaged and thus the increase in the speed of degeneration. The another example is synovial chondromatosis. Just go back, please. Synovial chondromatosis. Why synovial chondromatosis means there is a tendency, predisposition for cartilage cell shedding into the joint, and this cartilage, shedded cartilage, multiplies within the synovial fluid because it is aneural, avascular, gets nutrition from the synovial fluid, and this cartilage cells undergoes to become a cartilage mass and then later on calcified. So there is a condition called synovial chondromatosis which damages joint faster. Similarly, Marfan syndrome, hypermobile joints, they are more prone for secondary OA. Next. So, broadly categorizing inflammatory conditions, infective condition, anatomical abnormality causing incongruent joint surface, maybe AVN, fracture, Perthes, or certain situations where there is a Charcot joint, whether it is a post-diabetic, prolonged long-standing diabetic, or syringomyelia, or as I said, congenital insensitivity to pain, or there are certain cartilage deposition disease like alkaptonuria and other. So these are the condition which predisposes for secondary osteoarthrosis. Next. So summarily, maybe some genetic factor, maybe some developmental, maybe some metabolic, maybe some traumatic, and this degeneration of the joint is faster. Next. Now, this is the example which I talked about, synovial chondromatosis, and you could see here a lot of osteophytes have become within the joints, and this joints has damaged the joint irreparably. And this is what is secondary osteoarthrosis, secondary to synovial chondrogenesis in a very young patient. Next. Now, this is a fracture which has been fixed, very well fixed fracture, and you could see that the alignment is very well, but still there is some damage to the joint surfaces has taken place, and that is why it is likely to develop secondary osteoarthrosis. Osteoarthrosis may affect every joint. This is acromioclavicular joint, or even in the elbow joint. Just go back. And even in the spinal joint, because spine also has a multiple joints which is lying posteriorly as a facet joint, and the anteriorly the intervertebral disc. So any loss in the disc height produces the reactionary changes into the bone, or maybe hip, maybe metacarpal, knee joint. So any joint or every joint may be affected by osteoarthrosis. Next, please. Now this is the process. This is a kind of a section. You could see this all is bone, and this is about 5 millimeter thickness of the cartilage. Similarly, here this is the bone, and this is the thickness of the cartilage, and there is a parallelism given because by the meniscus, and this movement continues to take place smoothly. Now, whenever there is a degeneration of this cartilage is thinned out, and as a result, this subchondral bone undergo reactionary changes as a new bone formation, And similarly, when joint become unstable because of loss of this side, so some osteophytes is formed here, and that is how the degeneration takes place. And this is what is the whole cascade of degeneration. Next, please. And this can be understood by here. This is the normal joint, parallel. These two surfaces are parallel, and this is the subchondral bone. This is the cartilage thickness, subchondral bone. And once this all takes place, the irregularity and subchondral bone undergoes reactionary new bone formation and osteophytes formation, and these chondrocytes cartilage pieces, they may make a cartilaginous loose body, and that is how osteoarthritis is evolved. Next. And you can understand the various stages, that if the joint is normal, some part is affected, more part is affected, both side is affected, or third joint is also affected. So that is how this is called as stages of osteoarthrosis. To begin with a normal joint, gradually some part is damaged, the bigger part is damaged, gradually both condyle surfaces are, so this occurs, the process occurs in both part of the joint. And similarly patellofemoral joint is affected. So that is how the degeneration progresses. Next. And this is what the cartilage picture, normal cartilage with just some kind of a loss of color, loss of, and some kind of a loss of height, which undergoes fragmentation, and one could see a new subchondral bone is visible here. You could see here subchondral bone is visible, so there is an irregularity here, and as a result reactionary osteophytes new bone formation occurs into the ends of the bone and subchondral area, thickening of the bone, and this is what a stages of cartilage degeneration. Next. Now, once we understand these symptoms, pathology, what these symptoms are, pain may occur during or after use or after a period of inactivity. So these patients present first after a period of inactivity, and then gradually person may feel that he is little better, and then if continues to walk, then pain again during the walk. So this is one of the most common symptom. Joint stiffness more when one wake up in the morning, it means after a period of inactivity. So whenever there is a period of inactivity and overnight sleep, these patients generally complain of joint stiffness, and they feel that these joints have become less flexible. The range of motion has come down, and normally young person, if one is able to touch the toes on standing, bending forward, now after 50 years of age, because of the loss of flexibility, one may not be able to bend the body forward and touch the toes. On examination, tenderness present in the joint surfaces on light pressure, and on movement of the joint, a grating sensation can be felt. Certain bone spur which appear as hard bump may form around the affected joint, and there may be some swelling in the joint, and range of motion may be decreased. So patient may complain with any of these symptoms. Next. So if we take the hip as example, secondary osteoarthrosis is more common than primary osteoarthrosis, and it is a documented fact that generally hip does not go very rarely as a primary OA. Well, I think here I would like to tell that if you look at the literature, generally it is said that Indians do not have primary OA, and it is more of a secondary way. But I think whatever data has come up, it is all old data, and since the life expectancy has increased now, it used to be around 40 year around the independence, now it is almost 67 or 69 year. So now even the primary OA is starting coming up, but certainly hip secondary osteoarthrosis is more common as a result of some pre-existing disease than the primary OA. They present as a pain around hip, and which is referred to distal thigh and knee. Deformity, yes, there may be mild deformity like flexion and adduction deformity of few degree. Generally, osteoarthrosis does not give rise to severe deformity. Decreased range of motion, yes, on terminal movements are decreased, and since these heads are deformed, there may be some leg length discrepancy of few centimeter, or maybe because of fixed deformity, and the limb looks shortened. And since this pain hip is being affected, so the patient gets an antalgic gait, where person takes walks so quickly onto the painful side that wants to unload the joint, and that is why a very short. So they typically walk with antalgic gait. Next. Now, knee is the osteoarthrosis, which is more affects the patients. It is more common, and primary OA is more common than the secondary OA. Generally, they present around knee and calf. Medial tibiofemoral arthritis, more common. So these patients, if it is, I'll just describe this in next few slides. Generally it starts with medial tibiofemoral arthritis. So when these patients have pain on walking, and if the patellofemoral joint is also involved, then they complaints of pain on climbing stair, kneeling, bending, sitting with knee bent for prolonged period. Generally, it may start with one of the compartment, but involvement of all three compartments takes place, and muscle wasting, muscle imbalance and joint instability is found as a result of disuse cordyceps wasting. Next, please. Now, when we ask these patients to X-ray, then hip, X-ray pelvis with both hip, AP and frog leg lateral is to be done. And in all such instances, lumbosacral spine should always be done. While knee, weight bearing X-ray of both knee, AP, lateral, and patellofemoral X-rays for the patellofemoral joint should be done. Next. Now, what we want to investigate? We want to investigate by X-ray. We have made a diagnosis that this joint is osteoarthrosis is there. But what we investigate, we want to rule out secondary causes if history and examination suggest. So what are the secondary causes? Basically inflammatory pathology. So CBCs, ESR, CRP, rheumatoid factor, anti-CCP, HLA-B27, serum uric acid. It should be done to know if there is a inflammatory arthropathy. And for metabolic causes, serum calcium, phosphate, ALP, vitamin D3, PTH, and urine for crystal should be done. Next. So clinical approach, we know that now we have a more than 11% patients above 60 year has knee pain and osteoarthrosis of the knee. And when you look at their history, you go into the history, you ask certain questions about the characteristic of pain and the inflammatory, whether there is a fever or not, history of trauma, is there a history of trauma or surgery, instability, is there any functional loss? So this kind of a detailed information or a prior treatment we must obtain from these patients. Next. Do a physical examination besides vital, BMI, body mass index, palpate, as I said, isolate tenderness, effusion of the joint, crepitus, measure range of motion, stability, whether the ligament stable, menisci injury is there or not there. If there is an abnormality of alignment in terms of genu varum deformity of the knee or a valgum deformity of the knee, and how does it affects the function? Is the gait has changed, or if there is a Trendelenburg gait or duck waddle gait. And you might have observed elderly people with the bilateral knee pain, they suddenly, when they walk with the bending of the trunk on both sides. So that is called duck waddle gait. Next. Next. And we want to establish whether this pain is osteoarthrosis or this pain is of secondary inflammatory pathology. And the 3 of the 6 characteristics generally are present. That inflammatory arthropathy pain, they present less than 50 years, and OA pain, frank osteoarthrosis pain or osteoarthrosis because of age, they present beyond 50 years. They have a morning stiffness of less than 30 minutes, but generally inflammatory pathology, they have a morning stiffness more than half an hour. Crepitus, bony tenderness, bony enlargement, and no palpable warmth. Generally inflammatory arthropathy joints, they are little warm. So if 3 of the 6 are present, then we know that we are dealing with the case of knee osteoarthrosis. Next. And these are the various clinical tests which one should do it to know the instability of the joint, whether it is medial collateral ligament is weak, or lateral collateral ligament is weak, or anterocruciate ligament is weak, or meniscal injury is there or not. So these all clinical examination is to be done. Next. We have done this blood picture, and this is what I was talking about: X-ray, AP, lateral, and skyline view for patellofemoral joint. This is femur and this is patella. Now, weight bearing X-ray should be done, and I think I would suggest when we are investigating knee, we should make the patient on one limb stance, AP on left side and then AP on the right side. Why? Because if when the person takes full weight on one limb, then we know what is the impact of loading on the knee takes place, and that can be documented by X-ray. So this all should be done. So AP, lateral, and patellofemoral, tangential patellar or skyline view is to be done. Next. MRI, yes, MRI is done sometime to see the soft tissue damage, be it meniscal damage, or be it maybe a ligament damage. So the MRI is to be done. Now diagnosis. So diagnosis is generally clinically on X-ray by reduced joint spaces, osteophyte formation, subchondral cyst formation, and density, increased density in the subchondral area. And this is what is a classical classical osteoarthrosis, and one differentiate primary from the secondary by whatever I have conveyed in the previous slides. Next. Now, once you have made a diagnosis of osteoarthrosis, then it could be of varying grade, mild to severe. And this has been the most common grading is Callegren-Lawrence classification, which is grade 1 to grade 4. Grade 1, there is a doubtful joint space narrowing, and there may not be any osteophyte. And one could, this is practically a normal symptomatic knee. Grade 2, where there is a minimal definitive osteophytes and possible joint space narrowing. Next, please. There is another picture. So this is what an osteophytes and early joint space narrowing has taken place. So this is mild to moderate, and if it is multiple osteophytes, definite narrowing of joint space, and some sclerosis around the subchondral bone, then we know that it is a moderate. And in severe reduction of space, multiple osteophytes, sclerosis, so this is what is a severe, and that is how we classify from mild to severe. Next. Now, what I was talking about, single compartment or tri-compartment. In a normal knee, this is a medial compartment, medial part of the tibia and medial part of femur, lateral compartment, lateral part of the femur, lateral part of the tibia, and there is a joint between the patella and the femur. This is the patellofemoral joint. So there may be a situation, to begin with, it may be just a medial joint affection, where there is a cartilage damage to the medial side and all osteophyte, everything occurs medially. Later on, it might shift to laterally, or it may be all three part of the joint is affected, and that is called tri-compartment. And this is a very important bearing in planning and executing a treatment. Next. This is what that this damage has taken place. So damage is here, or damage is both, or damage is all the three. Next. Now, you have made a diagnosis, you have classified that how severe it is, you have understood, then how to manage. I think the lifestyle management is one of the most important part of knee osteoarthrosis, particularly in the early stage. So the most common is weight loss. As I said, for a normal walking in a single limb stance, 3 times of the body weight passes through the knee, and on running it is almost 5 to 6 times. So if one person is 50 kg or person is 90 kg, it makes an effect. And that is why if the person undergoes in a weight loss training and reduces weight, then strain onto the joint, in the joint which is already symptomatic, can be done, and that is why weight loss is one of the most important part of the lifestyle management. Must do exercises. Why exercises? Because the for weight transmission, the muscle has to take force, and they have to be strong, and that is why patellofemoral physiotherapeutic referral, quadriceps strengthening exercise, range of motion exercise, that you put the joint to complete range of motion. You know what happens is that in early stage of disease, when the inflammation there in the joint, muscle goes spasm, and as a result of spasm, hamstring and knee flexor are more powerful, so knee undergoes in 5 to 7 degree or 10 degree flexion, fixed gets into fixation in that flexion, and then if person walks in that 5 degree or 10 degree flexed knee, then the loading of the weight occurs at one particular point, and that is why instead of a universal and complete joint loading, it occurs at some point of area in the knee joint, and that damages the cartilage further. And that is why it's important that we achieve complete range of motion from complete extension to as much flexion, at least up to 90 degree. So range of motion exercise is most important. Quadriceps strengthening exercise is more important, and stretching exercise is most important. Now, low impact activity like swimming and biking, they are very useful for the osteoarthrosis knee. But sometime when it becomes severe, then one takes an ambulatory assistant device. Say suppose a very old person with a severe advanced arthritis, but person is not able to undergo surgical treatment, then if we provide a can in the opposite hand, the weight transmission in particular knee can come down by half or significantly, and that is why cane or walker ambulatory assistant can sometimes be of use. I think I have written insole and unloader knee braces, which I'm just going to talk in the few slides with the picture. Next. So what is a non-pharmacological treatment? As I said, weight loss. No, just go weight loss, where normal weight people have 20% risk of OA, while overweight has 25 and obese has 39%. So sustained weight loss is useful to reduce pain and improve function in obese patient. Water exercise program is very good. Physical therapy, range of motion is strengthening, I have already communicated, and these exercises is useful to reduce pain and improve function. Occupational therapy, assisted device, joint protection, and patient is to be educated about the problem. This all is the non-pharmacological treatment. Next. 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 No, just go back. Just go back. Just go back. Next. Neuromuscular training, balance, agility, coordination in combination with traditional exercise are useful to improve performance-based function and walking speeds. So sometimes this neuromuscular coordination gets damaged, gets broken due to symptomatic knee, and that is why when being treated by physiotherapy, you have to put into neuromuscular training as well. Next. Now, this is what I was talking about, that in early medial joint disease, some loss of the height takes place medially, and joint goes into varum, bends the inside, and knee goes outside, or vice versa. Here it is valgum, damage is more here, and as a result there is a valgum. Now in these situations, whether it is genu varum, we know that loading is occurring while taking weight here maximum, and in valgum like here. So next. So if you put these kind of loading braces, then that can deload the affected part of the joint, medial side or lateral side, and these are braces sometimes very useful, because you know the healing, cartilage healing will takes place naturally. Hyaline cartilage will get replaced into fibrocartilage, but it takes time, 2 to 3 months time. So if you put these in certain cases on these deloaded braces, then this cartilage may heal and patient may become less symptomatic. Next. Similarly, insole, well, there is not much data available on it, but yes, it does work in early osteoarthrosis. Say for example, if there is a genu varum and if one puts a lateral thickened wedge of 6 to 8 millimeter, and with no wedge, no thickness on the medial side, and put it as an insert into the shoe, then it also deloads the joint to some extent. So for varus, lateral shoe rows; for valgum, a medial shoe raise in sole is useful. Next. Now then we come to medical management. Medical management, there are certain drugs: glucosamine, chondroitin, acetaminophen, NSAID, COX-2 inhibitor, opioids, and then these are all tablet forms or oral, and these are certain intra-articular injections. Next. These oral dietary supplement, turmeric, ginger extract, glucosamine and chondroitin sulfate, well, they are controversial, not supported by many studies, but people do take, and data is not available. But I think people do prescribe turmeric for all that. And similarly, vitamin D may be helpful in mild to moderate osteoarthritis in reducing joint pain and improving function with inconsistent evidence. Next. Now, I think I would like to mention about the glucosamine and chondroitin. This is said to be a building block for glucosamine and chondroitin, but there are a lot of it's being used by the people. It is costlier also, but till in spite of it's being used by 30-40 years, but it's not been able to give us any concrete evidence that it does work. Certainly for milder OA, it is no better than placebo, and for moderate to severe OA, it is said in some of these studies that combination showed benefit, but there is not concrete evidence that glucosamine and chondroitin sulfase does work. And looking at the cost benefit, I think it is not much use at the moment. Next. As far as the drugs for pain, oral NSAID, non-specific anti-inflammatory drug, I think in all these conditions, we need a long-term therapy. And that is why paracetamol for mild pain, 1 gram 4 times a day, it is better than placebo, less than NSAID. However, next, NSAID like etoricoxib, aceclofenac, diclofenac are efficacious and safer for moderate to severe pain. But then, since these drugs are given for a little longer time, we need to be watch for renal and gastrointestinal safety, and accordingly one should think of prescribing these drugs. Well, antacid, yes, they are prescribed against GI side effect of NSAID. Next. But there are certain drugs like pantoprazole and all those group drugs, they can decrease calcium absorption. So we need to give better ranitidine, which does not affect much calcium absorption. However, because this will again be given for longer time, and that is why we should be using consulting physician to the longer use of one of these drugs. Next. Topical NSAID, yes, they improve function, quality of life, and they can be given when they are not contraindicated because of some drug skin reactions. Oral NSAID, as I said, all recommended to improve function, and the oral acetaminophen, paracetamol is pretty safer. But certainly oral narcotics and tramadol, they are not much useful, and they are also increased adverse event, particularly in old age, like narcotics sedation, constipation, and that is why they should be avoided in true or primarily osteoarthritis. Next. Now coming to intra-articular injection, there are various kind of intra-articular injections. One is hyaluronic acid, and it is not recommended for routine use, and despite multiple systematic reviews, the latest recommendation of American Academy of Orthopedic Surgeons does not recommend its use in the routine cases. Yes, steroid does give a short-term benefit. Next. The other intra-articular injections are platelet-rich plasma, stem cell, which may reduce pain and improve function in symptomatic osteoarthritis. Next. Now, intra-articular corticosteroid injection generally given in the for early improvement in pain and function within 1 week, but long-term efficacy, it does not go beyond 8 to 12 weeks, and long-term superiority over oral NSAID in patients up to grade 3 is controversial, so it doesn't work for longer time. So certainly a severe grade, it is not much of useful, and risk of accelerated osteoarthritis progression. Subchondral insufficiency fracture, osteonecrosis, and rapid joint destruction may take because of repeated and multiple use of corticosteroid injection. So generally, we do not suggest that these steroid injections should be used repeatedly, because it may like to damage the give rise to some insufficiency fracture, or repair is halted. Even otherwise, whenever it's to be given, it is a generally people tend to give, looking at the Western literature, they tend to give as OPD procedure. I think I strongly believe that in a Indian setting with the kind of patients we have, it should be given in an operation theater setting, so that all complete hygiene is maintained and we do not inoculate any risk of infection in the joint. Next. Intra-articular biological agents, yes, platelet-rich plasma formulation, autologous conditioned serum, mesenchymal stem cell injections, they are being used, contain anti-inflammatory molecules, attenuate joint destruction, and potentially remodel the joint, it is said, but no long-term large study to support their role. As of now, the evidence is very limited. Probably platelet-rich plasma or these have a role in early osteoarthritis when we are being treating with the with braces or with some other drugs, and we are aiming for naturally healing of the cartilage damage. Next. So this is what is the management algorithm. When you diagnose it, you start with lifestyle modification, paracetamol, then you add on to these NSAIDs. Sometime you at this point of time do some steroid injection. Opioid is not to be used, but yes, very rarely for few one may think of. Hyaluron injection, debatable, not to be given in advanced stages. However, we must look for when is the time ripe for a surgical referral. Next. Now, when surgery and what surgery? Arthroscopic joint debridement, joint lavage, not recommended because it doesn't help. It just washes the joint. So hence arthroscopic joint debridement has no role. The primarily three kind of intervention: cartilage reparative procedures, which has come up recently, where a smaller localized cartilage defect can be repaired, can be done reparative surgeries like mosaicplasty, where you grow the cartilage and you fill in you take some cartilage from healthy part of the joint and allow it to grow and then put it into the cartilage defect. Well, this is done for early stages and one requires a very highly specialized places. HTO, high tibial osteotomy or unicondylar replacement and knee replacement are done for advanced stage of diseases. Next. And this is what is HTO. We know that, as I said, there is a deformity. Just go back to the previous, go back. Yeah, no, just one click. Now this is a Januvarum, and we know that there is a single compartment arthritis, Januvarum or valgum, whatever. So in that case, we need to correct the mechanical alignment. This alignment so that loading weight transmission from here can spread to the whole knee joint, and we want to make this joint like this. So we want to correct this varum deformity. And this is generally done less than 60 year and less than 15-degree deformity. Next. And this is what is done, that we take a bone from the lateral side. Next. And as we close it, this is tibia is aligned. Next. And then it is fixed like this, and this deformity is being corrected. So this is called high tibial osteotomy. Next. Now similarly, sometime one does replacement of only one part of the joint, medial or lateral, and that is a partial knee arthroplasty, where we remove the surface of this femur and this tibia and insert metal and the metal over the plastic, and that is why these damaged surfaces are replaced, and that is what is a unicompartmental arthritis. Here all other structure of the joint are there. It increases the range of motion, faster recovery, and it is said it survives for 10 years. Next. Next. Now when all the three joints are all the three, just go back, all the three tibia, just go back, tibia, no, just next, but single. So this surface completely is changed, the whole femur is changed, and even the patellofemoral is changed, and that is called total knee arthroplasty, and it is done when all the three compartments are damaged. So indication: diffuse arthritis, severe pain, and functional impairment. Pain relief is very good, and one gets the functional gain as well. Now here, and these ligaments inside are sacrificed, and prosthesis survival is there for more than 10 years. I think now in the recent time, this survival has further improved to 15 years or more. Next. And this is how it is done, that this total knee arthroplasty is done with lateral ligament or medial ligament intact, and the anterocruciate ligament is sacrificed. Next. Now I'll just show you two examples. Can you just take off these 5 pictures? Just put this only. Now here, this is a right side joint and this is left joint, and hence both the joints are damaged, and the patellofemoral is not visible, but when generally these two joints are destroyed, then we are left with no other option other than the total knee replacement. Next. One picture, one click, and this is what is another bilateral knee. You could see the whole femur is subluxating on tibia, and here you could see this is almost kissing onto the tibia. Lateral. This next, and this is the lateral. You could see here patellofemoral joint is also damaged, and this you could see the osteophytes here and the osteophytes. Next. And this is the patellofemoral joint. There is a severe reduction of the lateral patellofemoral joint. Next. So here, but since the person was, despite such a severe joint destruction on X-rays, this patient was severely symptomatic here, and so he permitted us to do one replacement. So this has been done, and now it's almost 2 years. Person is still doing full activity. Despite radiologically seen this damaged joint. The whole idea of showing this set of X-rays is that looking at this X-ray, we don't treat the X-ray, we treat the symptoms, we treat the problem of the patient and not the X-rays. Next. So in conclusion, it is an osteoarthrosis is a disease of aging. Need to identify primary from secondary, treat secondary causes first, so that it may heal naturally. Use judiciously non-pharmacological option and pharmacological option. Some of them may require invasive treatment like intra-articular injections. Rarely surgery in selected cases. Now surgery is an elective surgery. Patient to decide when to get surgical intervention, so that the goal is remain mobile as much as patient can or we can. Thank you very much indeed for next. Thank you very much indeed for patient hearing.
Thank you, Dr. Jain, for your elaborate presentation on giving the basics, how it happens and how the disease is progressing, and what are the treatment modalities which are available. With this, house is open for questions. Meanwhile, sir, there are few questions here. If you allow, I can take up
Yes,
those.
yes.
The one question was about, I think you've already answered, role of opioids in the pain management.
Yeah.
There is no role of opioids. It's the inflammation that you're trying to reduce, and only non-steroidal anti-inflammatory drugs have anti-inflammatory activity. The opioids have only analgesic activity. Now, there was also one question about how much period or the, when non-pharmacological is a very important approach here for the management of osteoarthritis. How long this trial, or you should say that this is effective or not helping the patient? How much period should it
Yeah,
be?
I think we cannot put up the timeline to it. What I would say that if we treat it, we treat on expectant line by lifestyle modifications, by some braces, by medicines support, and in due course of time it should start showing improvement, because we need to understand it is the damage to the cartilage, and subchondral bone pain source is generator is subchondral area. So this cartilage will heal into a fibrocartilage, will take about 3 to 4 months time. So it is a long drawn process. And that is why one cannot put up a timeline that now it is 3 months and now it is not helping. Yes, if person is on an improvement trend and person is able to do his all activities of his life, then, but if for some reason, if life is disrupted, or if person is not able to keep oneself fit, or a person is not able to perform daily course of, then I think it's time that we should surgically intervene.
So, okay, let me put it, when should you abandon, when should you abandon to hoga nahi actually, intensify ही करना पड़ता है, because I think all throughout, whether if you do surgery or give injections, this non-pharmacological treatment remains important. So this needs to be continued throughout. But when should you intensify? Okay, I've given a trial, good trial. Patient has also complied with us, and then when do you add analgesics or intensify analgesics or go for other invasive procedures?
I think I would put it this way, that if there is a secondary osteoarthrosis where there is a mechanical damage to the joint already there, in that case expectant line doesn't work. Like post AVN, post fracture, post. So it means they will go for replacement very early. Now, primarily for primary osteoarthrosis, where the no physical damage to the joint has taken place, and now we are allowing the nature to heal up the damaged cartilage. So in that case, to my mind, 3 to 6 months time becomes a good time, which gives you a very good indicator that this patient is on an improvement trend. And if there is and we cannot continue anti-inflammatory forever. So that is why we support the anti-inflammatory when there is an acute pain, and then put it on paracetamol and braces and all those things. And if it is constantly being improved, but then patient education become most important part, because these patients, they force you to do some intervention generally, because at a very short time they say, sir main to pain se tang aa gaya, mera to kuch kariye. So unless they understand, and I'll give you one example, that one of my relation had a very severe young age knee affection and severe pain, and she was begging कि साहब तो कर दीजिए replacement. And we diagnosed that it's an inflammatory arthropathy. We gave all those drugs, braces and all that, and for some reason, for some family issue, she did not could not get anything done. In 3 months time she was 80% better, and now she comes back 1 year down the line for the opposite knee. So that time I said, now you tell me, you want the course which you had for the left side, or you want now get rid of this pain by intervention. So this is the bottom line, is that we need to understand patient is part of our treatment, and we understand what patient understand, and then we move on. If patient is symptomatically improving, range of motion improving, pain, basically pain is reducing, then certainly we continue on that line. And it is more often than not, first time symptomatic knee, second time symptomatic, they serve, and there is not much on x-ray, there is not much of deformity, then they can certainly for years they can be kept on all modifications.
Sir, I have seen both types of patients. Some people, will beg for some invasive procedure कि कुछ तो कर दो, and there are other patients, उनको बोल भी दिया है कि that you go for joint replacement surgery, but they don't go for it. What would you like to, tell them? Early replacement is good, or you can delay it as much as possible.
मुझे लगता है कि the bottom line should be the physical activity and a person's desire to done a daily routine, and then if one is able to manage, and one should have enough mobility to be cardiac, to attain cardiac fitness. So those all things should be there. Generally itna severe pain in younger patients, we believe that they have some inflammatory arthropathy or something, and that is why probably they might have to go intervention. But elderly, they sometimes, because of their sedentary life, they may not go. Now let me tell you, this x-ray which I have shown bilateral, it's not patient's x-ray, it's mine x-rays, and you could see the one side, and if you, any one of you can see me working from 6 in the morning and operating for hours. So it means it is not the x-ray which is going to decide when to get operated, it is me who is going to decide.
अरे सर, वो कई मैंने देखा है कि एल्डरली हैं, मतलब बहुत डिफिकल्ट है, 2 कदम भी नहीं रख पा रहे हैं, ऐसे वॉबलिंग गेट है,
Should
पर
get, then they should
सर्जरी
get
नहीं कराएंगे हम.
No, वो ठीक है. If a person does not want to get it operated, you can't help it. But they in such a severe pain, there is no need to suffer, because knee joint once
Yeah.
done, after 4 to 6 months, it's a very pain free, and it becomes part of your body. It's good. I think somebody has put up a question: does kneecap brace helpful in synovial chondromatosis? I think if synovial chondromatosis is one condition, if it is the joint is deformed, you have to surgically done it. And this x-ray which I had shown, I hope I could have put my video of a patient on, which I did 2 months ago. It was a young patient, bilateral synovial chondromatosis, walking ability hardly 10 steps, and now in about 3 months time he's just joining office. So this synovial chondromatosis, no brace helps. It all depends on biomechanical damage, the mechanical damage, how much, and then we should go, because these loose bodies, they come between the articulating surfaces, and with your movement they further damage to the joint. So it doesn't really, no brace is helpful if the synovial chondromatosis is the diagnosis, so long as it does not, sometimes these chondromatosis, they lie in the periphery, they do not affect the joint movement. But the moment they affect the joint movement and bony surfaces become deformed, as shown in this x-ray which I had shown, then it is worth, the braces doesn't have, you need to do surgically.
So there is a question about intra-articular corticosteroid injection, whether they lead to increase in WBC count.
The injection 6 months ago, and currently there is no physical problem like fever, but the CBC report has analyzed WBC. If knee is not bothering, then it could be something else. It could be, but yes, why may in a government setups, in Indian settings, I am very afraid of giving intra-articular injections, because some of these patients, they are subclinical tubercular, and they become aggressive in the presentation, and this we have seen in our institution quite a few of it. So unless warranted, You have ruled out the other causes of inflammatory pathology, and in an OT setting, you give.
How many injections, somebody asked, intra-articular injections can be repeated?
Uh, I think 2 or 3, not more than that, and that too over years, 1 month or 2 years, 1 year or 2 years.
Do antibiotics have any role in decreasing the synovial fluid?
No, certainly not. It is a reactionary fluid to the mechanical damage.
Okay. Does stress increase pain in osteoarthritis?
I think let's not take osteoarthrosis. Muscle spasm part and pain and the stress, they are all quite interrelated, and that whenever person is in stress, muscles goes into spasm, and well, that may be one reason. Yes, it may, you can say, because stress is definitely correlated with myofascial component of the pain.
Sir, regarding pain, paracetamol, we discussed about 4 grams per day is the dose. But many people ask whether these patients should receive this NSAIDs continuously or on demand is good enough, or you give intermittent courses like that. What is the best schedule that works for the patient?
I generally give intermittent, never continuous, and two, never the same brand, same group of drugs repeatedly, continuously. So, but if the patient has understood, then we generally tell that you do this exercise, you do this braces, you do this insole or outsole, whatever, and take these drugs for 2 weeks time. Give a give a holiday for a week, 10 days, and you will understand that how much you have improved in the inflammation. Generally, these patients in 2 to 3 weeks time, they are ready to leave the NSAID, and then we can give plain analgesic, but certainly don't continue on the analgesic for long.
Sir, I think one more, request from Dr. Jayan Srivastava was if you could, explain to the participants here how to differentiate between rheumatoid arthritis and osteoarthritis, because many a times in the periphery, they may get mixed up, and rheumatoid arthritis gets, delayed, interventions get delayed.
I think I made it one of the slide very clearly that these osteoarthritis is osteoarthrosis truly, and without any cause into the joint, if the cartilage degeneration and secondary changes, that is osteoarthrosis or osteoarthritis. Generally, it occurs in elderly, late age. However, if there is anything else into the joint, which may be rheumatoid, which may be gout, which may be alkaptonuria, which may be any crystal or anything, then the cartilage damage is faster. Now, inflammatory arthropathy, generally, they have a history of multiple joint involvement. They have a history of stiffness, morning stiffness, all that for more than 30 minutes. They have some of the wrist joint involvement also. So there are all those criteria of inflammatory arthropathy making it a rheumatoid, and then you take the support of lab investigation. So that is how you make a diagnosis of inflammatory arthropathy or rheumatoid arthropathy, and that is why all those blood investigation, be it maybe a uric acid, be it maybe, has to be done before labeling it as a true osteoarthrosis in a younger patient. In younger patient, true osteoarthrosis should be very uncommon, unless some hereditary disease like synovial chondromatosis. I think somebody has put up a question, difference between osteoarthritis and synovial chondromatosis. I think I've made it clear that degeneration of cartilage, cartilage shedding, and reactionary changes in osteoarthritis, and synovial chondromatosis is a disease which genetically mediated, where shredding of cartilage takes place within the joint at very young age, and these cartilage, they multiply, makes cartilaginous loose bodies, which later on calcify and ossify to become in loose bodies. So this is what is and it is always a multiple in number, and that is what is a synovial chondromatosis. It is never one. These are all multiple.
Are there any other questions? Someone is asking about specific exercises for osteoarthritis.
I think I'll take the example of knee first. See, physical some fermentation, hot fermentations to the joint, followed by stretching exercise. Stretching exercise means we want to attain complete extension. We want to attain as much flexion so that we stretch the ligaments. Then the strengthening exercise for quadriceps, strengthening exercise for knee flexor, that is hamstrings, and the tendoachilles, so that knee joint is constantly stretched as well as strengthened.
Side effect of glucosamine.
I don't know, because I think if you ask me in last 40 year, 35 year, I have not given prescribed glucosamine to single patient. I tell them, if someone tells me that I'm taking it, what should I do? We tell them that from my side, it is of no use, because I think अभी मैं बता नहीं सकता, पर मेरे ख्याल इसकी even the oral absorption बहुत poor है in drugs का.
And
So,
cost is the side effect, I think.
and yeah, that's right. So, well, they keep on taking, some of them keep on giving, but I don't think it has any role to play.
I think Dr. Anil Jain has answered all your questions. If there are any, we can quickly take up. I think we are done with the questions because it was so nicely covered. Overview, the broad approach was given. And I think timely referral is something that you will also advocate.
Yes.
What time, what do you think, when should they be referring to a specialist? Because most of these participants are from the district level. So they may not have orthopedics main department so when do you think that the good time to refer?
I think the best time is that when you see, you can differentiate between the cause of arthritis from inflammatory and all those investigations. And if by history and all those investigation, I think you can share this my PowerPoint presentation to everyone.
Okay.
So if you are able to make sure that the person is not having an inflammatory arthropathy, and then some varum or valgum mechanical axis, then I think better to have one opinion from the clinician, orthopedic surgeon.
So suppose the osteoarthritis has osteophytes have just begun. Is there anything, can you stop this, or uh, you know how do you remain functional for a longer time?
Osteoarthritis, osteophyte doesn't cause you disability and loss of function.
A pain, or
These are
maybe
these are these are manifestation response of the body to instability. Say for example, in knee joint, both subchondral bone are separated by 10 mm, 5 mm femoral cartilage, 5 mm tibial. Now this cartilage becomes thinner, 3 millimeter on either side. So 4 millimeter height has reduced. Now this ligament, they are of the same length. So there is a subclinical instability, which we do not appreciate. We do not appreciate because muscles takes over. And as a result to that, body tries to stabilize that subclinical instability by making osteophytes. This cannot be undone. Now, corollary to it, calcaneal spur is a very common diagnosis on X-rays. But once the pain is over, spur is going to be there forever. So spur is not the cause of pain. It is the inflammation at that site is the cause of pain.
Okay.
So it's the attachment of ligaments. These are inflamed muscle ligaments or caps. So that's the inflammation that is the cause of pain. So we treat the inflammation. Osteophyte does not bother you.
Okay, so it is the painkiller and the exercise which is going to help the patient.
Absolutely, absolutely.
Okay, because flexibility would be, I'm also going into that age now and experiencing some of these symptoms now. So I was wondering, if it can be stopped. I understand it cannot be stopped, but we can keep remain functional for longer time if we take care of our weight. I think take home messages would be that work on your weight. Obese patients would have greater difficulty. The lifestyle exercises, non-drug treatment. Amongst the non-drug treatment, is there anything which is very good? This acupressure, TENS, and all those things, modalities are available. What is their role in this
I think they
management?
do help, like say gentle massages. They do help on relieving the muscle spasm. So muscle spasm is reduced, so pain cycle is broken. So I think they these other measures they do have some role. So
I think there are no more questions. We can stop here. Thank you once again. We, on
thanks, Dr.
behalf of
Sangeeta. Thanks.
yeah, our honor to have you here, sir. We are so enriched by your experience in the field. I was missing you other day on Dr. Anil Arora's son's wedding.
No, I was there. I was there in the.
I couldn't meet you. There were so many people over there.
I thought in reception you were talking.
Yeah.
Yeah, because I reached at 8 and left at 9:45.
Maybe we arrived at that time.
That's it. Yeah, I left at 9:45.
Yeah, okay. Hot fermentation is benefit to OA.
I think, as I said, it is just to break the pain cycle, whatever helps the person. After exercise, ice packs; before exercise, some hot. So that's okay.
Thank you, sir.
Thank you. Thank you.
We will carry on with the post session now.
Yes. Thank you.
There is on some of the questions were given to them on these lines, pre and post. I hope after the session there are more wisdom and the scores improve. But that was the idea.
Thank you. Thank you, Dr. Sangeeta. Thanks.
Okay,
I'm
thank you.
leaving.
Thank you,
I'm
sir.
leaving. I'm leaving. Thank you. Thank you.
There is a post test link in the chat box. Please click on that, fill up that. I'm also please open that. I need your favor today. I'm doing a study on dementia. I wanted to know what kind of facilities or the requirement, how many patients do you see? There is a short questionnaire I have. It will be of great help to me to understand how dementia services should be streamlined. This is another Google Docs, so please don't confuse with the post test. It would be good if you can, answer this Google form as well. Post test link is there, feedback link is there, YouTube link is there. There are four things in the chat box. Please look at your chat box carefully and do both three things: post test, feedback, and this Google form that I have shared in the chat box for dementia. Your feedback helps us in improving the understanding your requirements and how and future topics should be taken. You can also suggest future topics to us. If we continue these programs, what are the topics that you would be interested in?
Ma'am, you're on mute.
Yes.
Next session is on nutrition deficiency in childhood, right?
Siddhi, what is the topic for the next session?
Nutrition deficiency in childhood.
Nutrition?
Deficiencies in childhood.
Okay, fine. Yes. Is this good? Do you want that? What all you want to cover in that?
I'm not really.
Hmm?
I guess we can continue with the same session, nutrition deficiency in childhood.
Yeah, that's important.
Yes,
How
ma'am.
much, when to give? Please also fill up this dementia. It will just take 5 minutes. It will help us in designing the services for that. If we know the requirements, we've got about 100 responses on that earlier. But coming from you, from the district hospital and below, it would be good to know how many patients and what is the problem.
Ma'am, I guess you are on mute.
I was attending to another call.
Okay, ma'am. I thought you are.
Yeah, I know. Today has been very busy day.
I guess we can.
Uh, yes, I can stay on for the dementia. This thing, please spare that. I just keep it open. Let's see if they can do it. Post-test, I've got so far 57. The pre-test was taken by 93 people. Please check. I think others are in the process of giving.
I have posted the email where you can write to us regarding our certificates, or if any issue suggestions you want to bring to our notice, you can just write on this email. And also, you will receive your certificates within a week, and the whole recording will be available on YouTube channel. It's NHSRC QPH channel on YouTube. It will be available within a week. So you can refer to the channel for any of the notes you want to take from the session. can we end it?
Yeah, sure, please. I thought, oh, sorry, I kept you waiting.
No, ma'am.
Okay, thank you very much.
Thank you.